Now, Dr. Murray, I think we'd benefit from having an overview of where we are so far and an indication of what's coming up next. And I understand you have some slides.
I do. I want to give a brief introduction just to tell you what we know at the present time. We know that there are lots of questions that we can't answer, but at least we can tell you what it is that we know. Now, the first thing that I think increases the interest in all of this is that the idea of MS as a vascular disease is actually not a new one. And if you look in 1848, which is many years before MS even had a name, the process was known by a number of people, and Rindfleisch, who was one of the early people who published about multiple sclerosis, felt that it was probably related to something about the vascular system. So the theory is actually quite old. It resurfaced again in 1939 when anticoagulants were discovered. And when anticoagulants were discovered, they were applied to MS patients, and they were used quite widely in treating MS, and that went on for almost 20 years. It was before the advent of the randomized clinical trial, so there were no clear studies to see whether or not it was any benefit. But after about 20 years, it eventually faded and then disappeared because it appeared not to have any benefit. But for 20 years, anticoagulants were used on the basis that it might be a vascular disease. Now, some of you know about Roy Swank's diet. Roy Swank was a neurologist originally at the Montreal Neurological Institute in Montreal, and he devised a diet for MS, and it was based on the idea that MS had a vascular basis, and so a low animal fat diet might decrease the obstruction in arteries in people with MS. And so that diet, which is still used by many today, was based on the idea that it was a vascular problem. And then in 2007, Dr. Zamboni first postulated this idea of CCSVI, the possibility that it was a vascular problem in MS, but not in the arterial system, in the venous system. Now, this is one of the demonstrations just to simplify the process. And if you can look at the blue in the diagram, it just shows that the venous system, which drains down to the heart, is draining away from the brain. And his concept was that an obstruction in the venous outflow from the brain would increase pressure back into the brain, and that might cause the deposit of iron, and then the reaction in the brain would be to both the pressure and the iron deposits occurring within the brain. The logic then would be to decrease the obstruction in some way. But initially he postulated that process, and then the thing that got a great deal of attention was the publication just a matter of months ago of a small group of patients by MS trial standards, only 68 patients, who were treated for the obstruction in their neck. And that's what, in fact, got a great deal of attention. When he published this, he indicated that 91% of the patients with MS appear to have some obstruction in their venous system in their neck. But looking at people who didn't have MS, nobody seemed to have this. So that's quite a dramatic appearance. However, a subsequent study done in Buffalo indicated that actually only a little over half of the MS patients had it. So almost half of MS patients don't have that problem. And also 26%, depending on how you count the patients that they studied, 26% of people without MS had these problems in their neck. So it made it a little less clear that the relationship with MS was an overwhelming one. And he emphasized in his paper, and for those who really want to know what the information from Dr. Zamboni was, it's worth reading the paper and seeing what's in the paper. He finishes by saying that the work is preliminary and requires further study. In his paper, he indicated that the relapse rate, the number of relapses that patients had, was improved in the 18 months after having the procedure, but only for the people who had relapsing remitting MS. And only in those with relapsing remitting MS whose veins stayed open after they had the procedure. because one group of patients who commonly had the azygous vein, they often stayed open. Those who had the internal jugular vein with an obstruction, a high percentage of them, over half of them, the veins collapsed again. And those with relapsing remitting MS in whom the veins collapsed didn't show any benefit. So, and if you took them all together, there wasn't any overall statistical benefit. The group of patients who had secondary progressive MS didn't show any benefit. The patients who had primary progressive MS did not show any benefit. It was difficult, as he pointed out himself, to differentiate the response in therapy because all patients were taking the accepted drug therapy for MS. So they were also on one of the, at least one of the 4 drugs for MS. And so it made that interpretation difficult. And although the MRIs appeared to improve, Dr. Zamboni indicated that it was difficult to interpret the MRI data because different MRIs were used, different standards were used, and the way the MRIs were done in the different patients were different. So the MRI data wasn't overly helpful. What we don't know is, because this was an open trial of treating a group of 65 patients, what we don't have is an ethical randomized control study, which is the standard way to differentiate treatment against non-treatment. And you could do that by short-term measures. Short-term measures are to apply a therapy and then look at whether the MRI changes or whether the relapse rate changes. That's in the short term. What people really want to know, however, is the long term. The long term is, if I take this treatment, whatever the treatment may be, am I going to be better than I otherwise would in 5 years, 10 years, or for the rest of my life? Those are the long-term questions about any particular therapy, but needless to say, it takes a long time to know that. And we also need to know if the benefits of the therapy outweigh the risks. We do have therapies in MS that have some substantial risk. They have benefits, and there has to be a balance between the risk you take and the benefit that you will get from the therapy. And also, governments and others want to know that therapies are cost effective. In other words, that the amount that the therapy costs is worth the benefit that accrues. Because benefits, some therapies are very expensive, but the benefit is very little. And there is a way of determining what the cost benefit of therapies is, and governments are very involved in that at the present time. So that is a brief overview of the things we know, the results that occurred in Dr. Zamboni's research, the initial results that came from Buffalo, and the questions and the way that we need to answer some of these questions in the future. But it will rely on the standard accepted way of determining how much benefit there is from this therapy. And some of the things we will know in the short term very quickly. For instance, the questions about the veins in the neck, the MRI, the relapse changes with therapy. You can answer those fairly quickly in the short term, and those are being addressed now. Long-term questions, what's the benefit in 2 or 3 or 5 years, obviously take large trials of a large number of people, followed for a very long time.
Thank you, Dr. Bray.